So we'll move on to our next presentation, Dr. Christian Rake from Odyssey. And just as a reminder, thank you to Odyssey for sponsoring our lightning talks this year. Dr. Christian Rake will be presenting SNOMED CT and Federated Cancer Research, what works and what doesn't. Christian?
Okay. Hi, everybody. This is strange because I don't know what you hear and whether you hear me, but you must be hearing me. Very good. Okay. All right. We're going to talk cancer. Application of SNOMED in cancer. And by that, I mean cancer research, real world evidence in cancer. And it's going to be a little bit of cold and hot shower. There's a German 1800s treatment. It's called Kneippkur, or cure of Kneipp. And what you do is you apply cold water alternatingly, cold and cold, warm and cold and warm. So that's what I'm going to do. Get a little bit of warm and a little bit of cold with respect to the SNOMED. Okay. So let's take an example. EAU, that stands for European Association of Urology, association is a professional society. And what does it do? It does a whole lot of things, but one of its outputs is to create guidelines. And guidelines are how treatments in cancer are defined. So, there are all these different cancers with all these different situations, circumstances. And the guidelines say, this is what you do, this is what you, this is how you have to treat the cancer. Okay? So one of them is about muscle invasive and metastatic bladder cancer. So how does a guideline work? You have a patient with a cancer, and then there are a bunch of criteria. And depending on whether or not the criteria are met or not met, there are different treatments that are recommended. So it's kind of like a decision tree. Okay? And so SNOMED seems to be like a resource which should be instrumental in order to be able to research this type of thing. Okay? So let's try. Let's type in muscle invasive and metastatic bladder cancer. 0 matches found in 0.48 seconds. It's not there. Well, maybe because it's actually two things, muscle invasive and metastatic. Let's try them separately. So let's type in metastatic bladder cancer. You get cancer metastatic to urinary bladder. That's actually the opposite thing. We need the cancer that comes from the bladder and metastasizes to another organ and not the other way around. So that's not the right thing. Muscle invasive bladder cancer, 0 findings. Really? So there's a guideline where several dozen medical professors use months to read through all the papers and all the studies to write a guideline for a cancer disease, and SNOMED doesn't have the cancer? It's not relevant enough? Okay. So what's the problem? Okay. The problem is the conditions aren't that simple and that straightforward. So if you take it, there's the term muscle invasive that describes the local growth. There's metastatic that describes the fact that the cancer spread. There's bladder, which is where the cancer originated. And there's cancer, that's the disease. It's a morphology, histology. Okay? And so all of these things are pre-coordinated together. And SNOMED does it pre-coordinates, right? But here's the problem. There are 1,800 or 1,900 invasions, extensions into other organs in SNOMED. 255 metastases, 37,000 topographies, 1,000 morphologies. But that's not all. There are stages, there are grades, there are biomarkers. The biomarkers alone, genomic markers, variants, mutations. The mutations alone in ClinVar has 205,000. So if you want to pre-coordinate everything so you have a existing SNOMED concept for every possible cancer, you probably will break SNOMED. SNOMED is famous for having a large number of concepts, like 400 something thousand now. And even if you're saying not all of these actually exist, not all combinations exist, okay? You can have a bladder cancer which has the histology of a melanoma, okay? That doesn't work, okay? But let's say a thousands only exists, or a millions. It doesn't matter how many zeros you cut off here, it's going to explode SNOMED. So it doesn't work. You can't do that. We have to just agree and be honest about the fact that not every possible cancer diagnosis can be had in SNOMED. So what do we actually have? There are cancers in SNOMED. Okay. Right now, the way SNOMED works and ICDO works, they both have the same thing. They define cancer as the morphology, which is kind of like what the cells do if you look under the microscope, and the topography, which is where it happens. Okay? And so SNOMED has 5,000 of those combinations, and they make sense. And bladder cancer is one of them. Okay? So we are good, right? We have 5,000 cancers. We're all done? No, we are not. Okay? So now comes the cold water. So far, we are very happy. SNOMED creates an environment where this research can be had, and it's systematic, and it's comprehensive, and there's no duplication, and it's very clean. But there are boo-boos, and we need to talk about these boo-boos. Okay? Some of these cancers have too few attributes. They are lacking hair. Okay? So, some of them, and this is 1,400 of them, they have no histology. It says breast cancer, or in this one, malignant neoplasm of vertebra. Okay? We don't know what type of cancer it is. That's not sufficient for research. You need to know what the nature of the cancer is. Then there are those which lack topography. It just says angiosarcoma, but not where. Okay? There are 278. There should be more because there are much more anatomical sites. So if you just want to say much more histologies, if you just want to say a cancer with this histology, either you should never have that because it misses one of the two legs, or you should have all of them and saying, well, that's a cancer where you don't have the topography. And then, of course, there are 31 of them, which essentially are random high-level concepts which really are no detailed at all, which is fine. SNOMED can have higher level and lower level. And then there are those which have too many attributes. They have a whole lot more here than you want. Okay? So there's the metastases. So there are some metastatic cancers. Not the bladder cancer, but some of them are there. Okay? This is bad. So either we have every cancer also as a metastatic one, or we don't do that, and the metastases are separate. Okay? We have to decide one way or the other. Otherwise, you have to constantly pick every time you do research, which one do you have? Do you have it? Do you not have it? It makes it very hard for the researcher. There is this primary cancer, which means that's where it started, and just a cancer. So if somebody says I have breast cancer, they mean primary breast cancer. So the cancer actually started in the breast. For some of them we have both. For some of them we have only one. For some of them we have the other. Can't do that. If we have primary, we always have to have them. If we don't want to do that, we have to get rid of them. Okay? They are explicit relationships that are defined very nicely. SNOMED defines relationships. So you can do this, right? There are therapy-associated ones. There are AIDS-related ones. There are recurrent ones or not. Same thing. If you want to have them, you have to have them for all of them, and not just 5, 10, 42, 4, or 12. We have 4,000 cancers. I want them all pre-coordinated with these guys. 2 more, very quickly. Then there are those which have relationships which SNOMED doesn't define and doesn't declare. That's actually bad, because it's bad by SNOMED rules. All attributes should be explicitly declared. Again, they're all over the place, but not many, and certainly not exhaustive. Okay? And finally, we have those, we have more than one histology, more than topography. Topography is actually not that bad, but the histologies. And oftentimes, they are 2 histologies where one is a subset of the other. You don't need that. If you have the other, you automatically have the one. Okay? So we need to figure out whether we want that and whether we want to have also combination of histologies, if that makes sense. So, SNOMED is an absolute godsend for anybody who does this, and we need to fix a few things to make it work.
Thank you so much, Christian. I'm going to bump my friend off the stage now.
That's right.
Thank you, Christian, so much. That was an excellent presentation.